Hello and welcome everyone to Ask Your Doctor. This is an informative health session that is sponsored by My American Doctor. We are a group of highly trained and experienced doctors that represent all specialties and provide second opinions throughout the country. We are not here to give individual health advice or treatment plans, but to just give a general idea of certain conditions. And if you have additional questions or need further clarification, you can get in touch with us. We do ask the live audience to ask any questions or to visit us at our website at myAmericanDoctor.com or to just give us a call at 919-914-941-494 to book a second opinion consultation with one of our specialists. Today, we have the privilege of speaking with Dr. Barry Craig Tedder, a renowned cardiologist and interventional cardiologist based in Jonesboro, Arkansas. With nearly 4 decades of experience, Dr. Tedder specializes not only in cardiovascular disease and interventional cardiology, but also in lipidology, a field focused on disorders of lipid metabolism. He is affiliated with St. Bernard's Medical Center and is known for his patient-centered care and commitment to heart health. Thank you, Dr. Tedder, for being here today. How are you doing?
Doing great. Thanks for having me.
Good, of course. So, in this conversation, we will explore topics surrounding cardiovascular risk assessment, lipid management, and cardiometabolic health, focusing on how patients can better understand their risk factors and treatment options. So, our first question here, Dr. Tedder, how do you typically assess a patient's overall cardiovascular risk?
Yeah, great questions. That's kind of the main thing a lipidologist does is look at the risk at different ages and try to come up with a treatment plan or discussion. So the lipid panel is, of course, the most important thing. We look at the four components, the cholesterol, the LDL cholesterol, the HDL cholesterol, and the triglycerides. But we also look at other markers of risk, blood tests that tell us about inflammation, like the hsCRP or inflammatory marker. We, of course, look at their blood pressure, but particularly the family history. If you have premature heart disease in your family, it's a big marker that we really want to kind of think about how do we want to evolve around that in our discussion. Lifestyle changes with heart healthy diet and exercise plan, quality sleep, and stress reduction. All those are involved in the risk assessment and trying to improve, the overall life with use of both medicine and lifestyle changes.
Awesome. So, what tests or indicators do you rely on most, especially for patients who maybe don't have any symptoms or family history of heart disease?
Yeah, a lot of people come to me because of family history, but if they don't have family history, you just kind of want to know what your risk is. You start with a lipid panel, but then I use a lot of other markers. I use often a panel called Boston Heart Lab, and we look at, besides the CRP, we look at some other inflammatory markers. I look at omega-3 levels, whether somebody's getting enough fish oil in their diet or supplement. I'll look at a homocysteine level to see if they're getting enough B vitamins to keep that marker down, which causes some heart problems. Um, yeah, and then we have a discussion. It's a patient-doctor discussion. Is it reasonable at a certain age to start on medications? The ideal goal is to start early, for a longer period of time. So I think sometimes in the 30s and 40s, it's definitely a time to decide what is my long-term cardiovascular risk plan. The real reason behind that is because it's a 30 to 40 year disease process. It starts in the teens with a little bit of plaque building up and getting into the arteries, and over time gets worse. So if we're going to prevent it, we have to start earlier, which is some of the mistakes we've made in our guidelines. I think that we wait until we have these, high risk score or you've already had a heart attack, and then we start treating, which I think is backwards.
Yeah, yeah. I think we see that a lot. Kind of just wait till it's too late or until something is a problem before we actually seek help or attention for it.
We really need to be proactive instead of reactive to, preventive care.
For sure. Yeah. Thank you for sharing that. Our next question here, if someone has moderately elevated cholesterol levels, but maybe no other risk factors, do you think they would still need treatment?
Yeah, that depends. We use what's called risk enhancers. So, if there's a one of these blood tests that I talked about, they show that it may be the patient has some other risk, or let's say they had premature menopause, which is a risk factor, or high lipoprotein A, or uh, other things. The blood pressure is a little elevated, but they don't, that's a risk factor. But we look at some subtle things that are not always obvious that may, even like psoriasis or inflammatory diseases, can be another risk modifier. So we look at it all, and then it's a patient-doctor discussion. You have a moderately elevated LDL cholesterol. We decide, okay, is it lifestyle with exercise and diet, or do we add medications at this point? I think it's a combination of both, and it just depends on what the patient wants to do at this point. If they don't have a lot of risk factors, we have guidelines that tell us what to do, but it's a patient-doctor discussion to say, I'm worried about my heart disease because I know most people die of heart disease as number one cause of death for everybody in the world. So maybe we should start earlier. So we have that discussion and decide about medications or not at that point.
Yeah. So how do you balance lifestyle changes versus starting medication in these cases then?
Yeah, I mean that's the discussion. I'm a pretty proactive medication user. Sooner the better. I feel like, I can even personally attest to that. I probably started my cholesterol medicine too late in my 50s with a 0 calcium score, and now it's a 500 calcium score, and I didn't change my lifestyle soon enough either. So there's a lot of things that if I would have started earlier, I may have had less buildup. Now I've not had a heart attack, but it's, the whole goal is that decision. Lifestyle's great. It's important. I think it's a combination of both for most of us. It's just a decision about when to start the medications and how early in life.
Yeah, yeah. So we always hear about cholesterol, good and bad. Could you explain how these fit into the broader picture of cardiovascular risk?
Yeah, I mean, I always found the lipid panel is a great window to look at what a person's overall body metabolism is. So if we look at the triglycerides, when it's high, which is common in the South Asian population, and the HDL, the one that people call the good cholesterol, and it's low, that's often an early sign of prediabetes or insulin resistance, which diabetes and prediabetes cause cardiovascular disease at an earlier age. The LDL cholesterol, which is the one that we're often focused on because it's the one in circulation the longest and tends to get into the arteries and cause the blockage problems, is one that if it's over 190, then we're worried about an inherited problem called familial hypercholesterolemia, which causes somewhere between a 3 to 7 times risk of having heart disease 10 years earlier. So when we have that, even at a young age, we want to start medications when the LDL is over 190, pretty much at any age. So we'll get on the cholesterol medicines, statins and ezetimibe and things like that sooner rather than later if they have a very high LDL. So the whole panel kind of is a real good window into that. Now, if your triglycerides are normal, your HDL is normal, your LDL is a little high, and then we start looking at other risk markers to decide if it warrants treatment and at what age.
Okay, awesome. Well, we did get a question here from the live audience I would love to share. And this comes from Sabir Sufi. In India, diets often include high carb meals, fried snacks, and sugary treats that are deeply tied to our culture and celebrations. What practical strategies can help Indians manage cholesterol effectively without completely giving up these traditional foods? And how do genetics play a role in our cholesterol levels? Great question.
Oh yeah, absolutely. I think in a little bit we're going to really dive deeper into the whole South Asian risk. But when we start with the diet, there's a great resource on the National Lipid Association website where they actually have diets for different cultures. And the Indian diet, unfortunately, we have a lot of metabolic syndrome and or pre-diabetes and diabetes, which is rising very, very highly and continues to rise. And a part of it is the cultural diet. Even though a lot of people are vegetarian, they use a lot of fried oils. So one of the practical things is switching from like palm and palm kernel and coconut oil cooking to using olive oil or canola oil for cooking, eating just less ghee and less saturated fat, using different oils, cutting back on some of the starchy things and eating a lot more, adding more vegetables in the diet, leaner meats such as chicken and fish, if you're not a vegetarian. So, I mean, there's a lot of little practical things, and I kind of look at this, handout, and I love Indian food, but we want to incorporate more vegetables, and less sugary. And the other thing is sugary drinks, like the sweet lassi, is getting rid of a lot of the sugary drinks and limit the sweet desserts by eating more fruits. And salt intake can be a problem for blood pressure too. So, start little changes at first. You can't just abruptly change your whole cultural diet, but little changes, small amounts, little at a time, and work your way down.
Yeah, awesome. Well, thanks for answering that live question for us. Our next one here, how does lipoprotein A fit into cardiovascular risk assessment?
Yeah, there's a lot coming out on lipoprotein A. It is a cholesterol particle similar to the LDL. Cholesterol particles are carried in the circulation. Fat and oil don't mix, so they have to be inside a protein that has an outside surface that keeps it from mixing. And then the lipoproteins, or the cholesterol in the lipoproteins, can get into the arteries and cause blockage, and that's the main cause of arterial blockage. Lipoprotein A is a very atherogenic particle, more so than LDL, meaning it causes more blockage problems, more heart attacks, more problems. It is very common, 1 in 5 in the world population, and South Asians tend to have a little bit more common high lipoprotein A. So that's definitely something that should be checked. It's now recommended by all associations to have it checked once in a lifetime. It is genetic typically. So if you have it once, it doesn't change. It helps you guide your therapy. So if it's high, you're going to be much more aggressive when everything else, including LDL lowering with medications and lifestyle, blood pressure, everything should be more aggressive if you have elevated lipoprotein A. So definitely an important marker to at least draw once in your lifetime.
And so what is that lipoprotein A exactly? Like, what is that? Does that come from foods that we eat or a certain like synthesis
No,
or something?
no, it's not coming. Well, most of our cholesterol and our lipoprotein particles that circulate in come from the liver. Some is
Okay.
absorbed in the gut, but lipoprotein A is all made in the liver. And like I said, it's genetic. It's something that you've inherited, that your liver makes more of it than other people. But no, it's not dietary at all.
Okay. Okay. So there is increasing talk
Oh, I'm
about,
sorry. And by the way, medications will be coming out in the next few years. Currently, you get about a 20% lowering with the Repatha or Praluent, the PCSK9 inhibitors, but not many drugs lower it now. So there's no good treatment currently, and that's why a lot of people don't draw it, but it is important to know your level. So in the near future, probably within a couple of years, there will be medications for it.
awesome. Yeah. Um, yes, increasing risk about the kind of lower for longer concept in lipid management. Could you explain what that means and why it's important in preventing these certain heart events?
Yeah, yeah. The National Lip Association is kind of pushing that now, and I've always believed that lower for longer means start earlier in life, and we keep your lipid, your LDL or your ApoB, your cholesterol particle levels down longer in your life. You're going to have this exponential decrease in risk, meaning that if I start at 30, 35, and I keep my LDL at 60 or 70 versus 120, then my lifetime risk of having heart blockage and heart attacks is going to be dramatically reduced, even if it's a small reduction. Whereas if I wait till like I did, until I was 50, then it's a little late for slowing down the disease process. So lower for longer means start earlier, keep your lipids lower longer, in addition to the lifestyle changes we've talked about.
Yeah, yeah. So I have a question here. So like someone like me, I'm in my kind of late 20s at this point, and I'm not really sure of my family history. Do you think it would maybe be a good place for me to go into the doctor and kind of get these things checked, or maybe wait a few years until like my early 30s to kind of see what's going on?
Well, it's recommended that one has a lipid panel at least once every 5 years, and you should have had one at age 9 to 12 as a screening.
Mhm.
So knowing your lipid levels is important for anybody. And so you would
Mhm.
screen out whether you had this LDL over 190, which would be a very high risk. And
Mhm.
also, like I mentioned, the lipoprotein A. You should ask your doctor for LP little a level, lipoprotein small a, because it's recommended once in a lifetime. And if that's there, then you'll know at age
Yeah.
28, oh, I got to really start working at least on lifestyle, maybe
Yeah.
medications if it's very high. And there's nothing wrong with being on medications at a young age. I think it's not been done over time, but we should be looking at 30-year risk instead of 10-year risk, which most of our calculators are 10-year risk, which is really not going to stop the disease early enough. As mentioned, cardiovascular disease, the number one killer, and stroke and cardiovascular disease all are hand in hand, all the same problem. So if we're going to stop the number one killer of everybody in the world, we've got to start at an earlier age to think about it, at least. And start with lifestyle and exercise and all that, but medications, when it's very high or there's high risk.
Yeah, yeah. So we talked earlier about the South Asian population and that they face a much higher risk of developing diabetes, metabolic syndrome, premature coronary artery disease compared to these other populations. So from a clinical perspective, what factors contribute to this elevated risk?
Yeah, I mean, this is a real big problem. South Asians make up 20 to 25% of the world population, yet they account for 50 to 60% of the cardiovascular morbidity and mortality. So they outweigh the risk. They have heart disease 10 years younger than other populations, which is astronomical. So the 50% of coronary disease deaths occur before age 50 in the South Asian population, and 25% occur before age 40. What that tells us is we need to be looking earlier, screening earlier, treating earlier in this population to improve risk. Now, one of the biggest risks is the metabolic syndrome or prediabetes or diabetes, which tends to occur without as much truncal obesity, meaning the belly weight. So the measurements for metabolic syndrome are actually lower for South Asians than they are for the rest of the world to determine it. Now, they still have a lot more what we call visceral fat, meaning the fat in the belly that gets into the organs, despite having not a very big waist size. So and one of the reasons is there's less muscle mass. So that tells us also South Asians need to be exercising more. There has been some sedentary behavior in a lot of South Asian population, and really getting out and exercises to improve muscle masses improves this metabolic syndrome or this pre-diabetic. The rate of diabetes is going up astronomically in South Asians. So we really have to address that's pre-diabetic with both exercise and diet and sometimes medications, and certainly aggressive medications if already diabetic. So the lipoprotein A, which is elevated a little bit more in South Asians, needs to be looked at and eventually addressed with medicines, but now with aggressive lipid-lowering therapy. And so the Indian National Lipid Association has come out with guidelines in 2023, which can be looked up, and it's very much more aggressive than the world or national guidelines we have elsewhere. Their targets for LDL reduction occur earlier in life and more aggressively on the risk assessment. So maybe for me as a Caucasian white person, I might not be as aggressive on me as it would be on a South Asian that has the same risk profile, just because they have disease 10 years earlier than other people. So yeah, it's a real problem that is not addressed as aggressively needed. And part of the problem is South Asians tend to have very aggressive, particularly if they have a family history. So if a South Asian has a family history of premature heart disease, let's say a heart attack in the 40s or 50s in a male or female, and then that daughter or son really needs to be looking at their numbers, being more aggressive in their risk assessment and treatment because of that high risk of premature heart disease.
Yeah.
I don't know if that covered it adequately.
No, that was great. Yeah, yeah. So when we talk about kind of those Indian guidelines for lipid management and such, when you say aggressive, do you just mean kind of starting earlier, getting on top of medication and kind of lifestyle? Is that what you mean by a little bit more aggressive approach?
All of the above. Lower for longer. Yeah, lower for longer. I mean, there's recommendations for starting calcium scoring screening at age 30 for people that have risk, like a family history or blood pressure or smoker, or all those risk things that we know about, that cause problems. And in the other guidelines for other people, it's more like age 40. So starting age 30 for high risk or moderately high risk people, family history, getting the calcium score. And if it's, over 100, they're going to fall in a category to push their LDLs under 70 or even higher, under 55, and even some people under 40 on the LDL is in the guidelines. And so, we use you can't get there often without medications. So we use the statins and the ezetimibe and the other drugs to get down there,
Yeah.
lower for longer.
Yeah. Yeah. I know we typically see a lot of patients who maybe are a little bit nervous to come in, or they don't really want to understand these things. Sometimes it can be kind of scary. So I think to offer that to some patients, that it's okay to come in, even if you're a little bit younger too, to just kind of see your risk factors and to understand what steps can we take to just live a healthier, longer life. So it's okay to come in, even if you're in your early 30s, late 30s, it's okay to start early. So my next question here is, if a patient is on lipid lowering therapy, but their LDL cholesterol levels remain above target, what would be the next steps there?
Yeah, you mean like if they're on a statin like Crestor or Lipitor, then you would talk about using ezetimibe as the next step. And these drugs are cheap, so that's what's beneficial. Is I pretty much have everybody on a statin and ezetimibe to start with because it's cheap and easy, and they work very well together. You get a 20% reduction with Zetia, and the statins will reduce the LDL anywhere between 30 and 50%, depending on the potency. One thing that South Asians have to be concerned about a little bit is they have higher levels of the statin medicine uh, at lower doses. So we usually kind of have to start at lower doses with South Asians. So like 5 milligrams of Crestor or no more than 20 is something that's talked about. So the PCSK9 inhibitors are the next step, which are injectables that lower LDL cholesterol fairly dramatically with very low side effect profile, and like 50 to 60% really can get the LDL down to those 30, 40 levels that we talk about for the extremely high risk South Asian. So yeah, those are the big three. We have long acting drugs called inclisiran that is twice a year drug that is useful. It's also an inhibitor of PCSK9, which helps the LDL receptors that take the cholesterol out of the bloodstream into the liver and dispose of it, recycle. So there are more of the receptors on the liver. Those are kind of the main drugs that are used right now. Newer ones coming to the market in the next few years.
Awesome. Yeah. So when we talk about these long-term use of these medications or statins, many patients can show some concern about the long-term use of that. So how do you address concerns around safety and side effects in these lipid-lowering treatments?
Yeah, that's a great question because we come up with that all the time. We have people coming in and say, I really don't want to take a statin. I want to do it with lifestyle. And I know that's a little frustrating for me at times when I have a very high risk patient. However, you kind of have to meet them where they are. You have to discuss what are your concerns, what is it you've read or heard on the internet. But what we know from hundreds of thousands of studies that statin therapy is extremely safe. Now, there are side effects, so we always have to be aware and discuss the side effects. The most common is muscle aches and pains, and that can be debilitating, and people will have to stop their medicines for it. So it's often if you try one, then you try another. We'll use a lot of vitamin D to prevent muscle pains, a lot of deficiency in vitamin D. That sometimes helps. Some people like to take CoQ10, and that sometimes helps for muscle aches and pains that come with it. But it occurs in somewhere between 5 and 20%, depending on how you define it. But there are studies showing that people that took a statin thought they were having myalgias, and they gave them what's called a nocebo, meaning they told them it was a statin, but it wasn't. They still had muscle aches. So it's sometimes we exercise hard and our muscles aches and we want to blame it on the medicine, and it's not always the medicine, but it often can be. So we have to work with our patients. We have to discuss the risk benefits. We tell them about how we can reduce their heart disease risk by 30 or 40% from having a heart attack by being on a statin that does that. And it has so much, clear-cut beneficial effects over hundreds of thousands of patients that we know the risk, we know the safety, which is very good. Just got to understand the side effects. And some people can't take them, and we use the alternative drugs. There's also bempedoic acid, which I think is available in India as well, which has a low risk of muscle pains as well, which is a pill. It also gives another, 20% reduction.
Yeah, yeah. Yeah, so anyone listening to the live chat here, if you have these questions or concerns, feel free to ask your doctor. They're here to walk you through things. And a lot of times we see just different things on the internet with, the rise of Instagram or TikTok. There's just a lot of information out there these days, but these doctors are here to help any questions or concerns that you guys do have. So lastly here, what would be your key message to individuals who may not have symptoms but are unsure of their cardiovascular risk?
Yeah, I mean, I think that's a great question. I think everybody needs to know their cardiovascular risk. I mean, you start with the lipid panel, and there's other blood tests like lipoprotein A you should have. You should know about blood pressure and what a normal blood pressure is and have yours checked. A normal is under 120 over 80. It's a lot of people are over that. We didn't know about smoking and smoking cessation and the risk of that. Diabetes, pre-diabetes, metabolic syndrome, high triglycerides. That's another problem that we have, some drugs for, but is often better treated by improving your diet with lower starchy carbs and bread, pasta, potatoes, those kind of things, and getting rid of sugary foods in your diet. So, just starting with the lifestyle component, exercise is so important. It reduces so many diseases to exercise regularly, both to build muscle mass by some weight work as well as aerobic exercise like walking, running, swimming, those kind of things. It's as good a drug as anything for so many diseases, not only heart disease, but cancer and Alzheimer's and all those exercises improves it. Yeah, and when we work on quality sleep and stress reduction as well.
Yeah, awesome. Well, thank you so much, Dr. Tedder, for sharing your insights with us today. Your expertise in cardiovascular prevention and lipid management definitely helps us shed a little bit of importance and light on these early assessments. So we thank you so much for your time. We appreciate everything that you've shared with us today. Is there anything else you would like to say to the audience before we hop off this conversation?
Yeah, just know your lipids, know your LPA level, and kind of know what they mean, and know that heart disease is very common, and we got to start earlier in our assessment and our treatment plan to prevent it.
Awesome. Well,
Thank you
thank
for
you so
having
much for your time. I appreciate it. Have a
me. Yeah,
wonderful day, everyone.
you too. Thank you.
Thank you.